So in the bladder cancers, the recent updates are regarding the histological subtypes. So basically, there are three terminologies which we should be aware of. The first one is variant, the second one is subtype, and the third, what is the difference between variant and subtype? So variant basically is the terminology which is now reserved for any kind of genetic mutations or any kind of genetic changes which is happening. So that is now is called as variant. So in histological terms, because as a pathologist, we tend to use the terminology histological variant. So the variant is now the terminology which is reserved for any kind of genetic aberration, not for the histology or morphological things. Then we have histological subtype. So histological subtype basically is a entity which has a distinct histopathological features, and it has got a prognostic implication. So these are in bladder cancer, these are the various histological subtypes like nested subtypes, large nested subtypes, tubular and microcystic subtype, then micropapillary, lymphoepithelioma-like subtype, then plasmacytoid and sarcomatoid subtype. We will see these entities one by one. Then there are certain divergent differentiation which we can see in a bladder cancer like squamous, glandular and trophoblastic divergent differentiation, though they have not got any prognostic significance as such. So this is basically taken from WHO 2022, where these updates have been mentioned about the term variant and subtype. So first is the nested subtype. Again, this nested subtype, it's an aggressive type of neoplasm, and it has got a deceptively bland histological appearance. That's why it is important to recognize this entity, and it resembles von Braun's nest when it infiltrates lamina propria. So this is the histological picture where you can see the nested appearance of this particular tumor. You can see the nuclear morphology. It is not a very high grade nuclear morphology, but yes, it is important to recognize this entity because of the prognostic significance. Then secondly, then we have tubular and microcystic subtypes. Again, these are, you can see these lumina over here, and the microcystic degeneration, and the pink secretions over here as well. Then micropapillary subtype. So we all know papillary, difference between papillary and micropapillary. So for non-pathologists, the papillary is one which where we have the fibrovascular core, whereas the micropapillary is the papillary projection without any fibrovascular core. So this micropapillary subtype, yes, you can see these modules of these tumor cells and then some retraction artifacts as well in the part B of this photo micrograph. Now, when do we call a micropapillary subtype? So when we see at least 10% component of micropapillary component, so then the tumor will be called as the micropapillary subtype of urothelial carcinoma. Importance of this entity is that it expresses HER2/neu. So we will have the targeted therapy against this particular entity. That's why it's important prognostically that HER2 inhibitor therapy, that is trastuzumab, is available for against this entity. Then we have lymphoepithelioma-like subtype of bladder cancer. So this particular tumor, so it does not show EBV association as we see in a nasopharyngeal region. So lymphoepithelioma-like subtype, the importance of this tumor is that it expresses PD-L1, and then the therapy against PD-L1 can be instituted if we identify this lymphoepithelioma-like subtype in bladder cancer. Then we have plasmacytoid subtype. So the plasmacytoid, as the name suggests, it resembles the plasma cells. The morphology is plasmacytoid. The cells, they will have eccentric placed nuclei with abundant cytoplasm. So this we can see over here in the micro photograph. Now, this plasmacytoid subtype is again an aggressive type of tumor, aggressive type of bladder cancer. And here we can identify CDH1 gene alteration, and it will show positivity with CD138 and GATA3 with loss of E-cadherin. As we can see, in loss of E-cadherin we can see in the diffuse type of gastric carcinoma as well. Then a sarcomatoid subtype, it is again a aggressive subtype of bladder cancer, and there we can see a lot of PD-L1 expression is increased. So then PD-L1 therapy can be instituted if we identify this particular subtypes. So in a nutshell, basically these various subtypes of bladder cancer, there are one or more therapeutic targets which are available. Say for example, micropapillary subtype HER2 is expressed, and then the trastuzumab is available. Likewise, there are subtypes like sarcomatoid plasmacytoid, where there is more of PD-L1 expression, and then we can have the therapies against these. Now coming to prostate cancer, because only the 20 minutes time was given. So briefly I had covered bladder part, and now I'll be coming on to the prostate. So in the prostate, in WHO 2022, what are the various updates? So there are updates related to the change in the nomenclature and terminology, part of which we have covered. Then there are prostatic ductal adenocarcinoma and pin-like adenocarcinoma. Then intraductal proliferative lesion. There are cribriform growth pattern. Then how to report or tertiary growth Gleason pattern. So what are the updates on that? Then treatment related neuroendocrine prostatic carcinoma, very important entity, especially in our setting. And then certain updates about molecular genetics. So we will see these things one by one. So first of all, how can I go back? Sorry. Sorry. So prostate carcinoma, because there are a lot of prostate malignancies which may involve prostate, because it is lying in the vicinity of the bladder. So the prostate tumors, they are basically confined to the primaries of the prostate. So we have the glandular neoplasm, where the benign entity prostatic cyst adenoma, then high-grade pin, intraductal carcinoma, then acinar and ductal adenocarcinoma, this we all know, and then the new entity treatment-related neuroendocrine prostatic carcinoma. So these are the elements which are covered in the glandular part. Then the basosquamous part, we have adenosquamous carcinoma of the prostate, then squamous cell carcinoma, and the adenoid cystic or basal cell carcinoma of the prostate. So the updates about these we will see in subsequent slides. And regarding the mesenchymal tumors, we have stromal tumors of the prostate, where we have a stromal tumor of uncertain malignant potential, and then prostatic stromal sarcomas. So these are very rarer tumors, the sarcomas and the stromal tumors. So in the change, so this is what we had actually discussed. So these are the nomenclature and terminology changes which has happened in WHO 2022 on say in general for the entire genitourinary tract, that the variant, subtype and histological pattern. So variant, again, it's a genetic aberration which it is earlier used in the morphological sense, but then as a pathologist we have to exercise caution that we should not use the term variant in terms of in context of morphology. Then subtype, we had seen that it has got a prognostic significance, or it has got an implication with differential diagnosis. And the histological pattern, so the histological pattern is the pattern, the distinct pattern, but it will not have any prognostic implication. So in prostatic acinar adenocarcinoma, will have these subtypes like signet ring cell like subtypes, when more than 25% of the tumor area will comprise of exclusively signet ring cells. Then sarcomatoid, pleomorphic giant cell, and pin-like carcinoma. So these are the subtype of prostatic adenocarcinoma. And these are the patterns like atrophic, pseudo-hyperplastic, mucinous, microcystic, foamy glands. And then coming to prostatic ductal adenocarcinoma. The prostatic ductal adenocarcinoma, it is again as a term, it is reserved for prostatic adenocarcinomas in radical prostatectomy specimens. So none of these things should be actually kept in mind, that the diagnosis of prostatic ductal adenocarcinoma should be given only in radical prostatectomy specimen, where more than 50% of ductal morphology is present. In biopsy, if we identify these elements, so then we should call the terminology prostatic adenocarcinoma with ductal features. And then on radical specimens, then we should try to identify it. Histologically, we can see these columnar cells with the tall columnar epithelium with the abundant cytoplasm, which is more of a columnar side, and then some stratification as well. Then Gleason's grading. So the major changes of Gleason's grading, it has happened in 2014, which we all are aware of, where we we give Gleason score and then we give Gleason grade and then grade group 1, 2, 3, 4, and 5. This we are all aware of. So now what has happened in WHO 2022? So in WHO 2022, the terminology WHO grade has to be mentioned rather than the Gleason grade. So this is the one update. Then coming to basal cell carcinoma of the prostate. So in basal cell carcinoma, because the term is very much similar to the basal cell carcinoma, which we see in the skin. So the terminology now is the adenoid cystic basal cell carcinoma of the prostate. And it also shows the MIB NFIB fusion, which we see in the adenoid cystic carcinoma of salivary gland. So it is akin to salivary gland adenoid cystic carcinoma, but the terminology again we have to be cautious. We have to use the terminology adenoid cystic basal cell carcinoma of the prostate. Then prostatic ductal adenocarcinoma. So we all know prostatic acinar carcinoma and ductal carcinoma, they are two distinct subtypes of prostatic adenocarcinoma. And this prostatic ductal adenocarcinoma, it will show, say, in 10% of the cases in, say, periurethral region, when we identify this prostatic ductal carcinoma, it may not have a prostatic acinar carcinoma, but in other senses or in other things, it will be kind of found in conjunction with the prostatic acinar adenocarcinoma. So purely ductal adenocarcinoma, it's very rare. Then we have pin-like ductal adenocarcinoma. So why pin-like? Because if we see the morphology over here, it resembles the prostatic intraepithelial neoplasia, where we can see stratification. And if we perform the immunostain, so the basal layers, it will be maintained. It will be lost over here, whereas it will be maintained in the prostatic intraepithelial neoplasia. So in pin-like adenocarcinoma, we can find these crowded glands, and it resembles the Gleason score 3+3. And here in the middle part of the photograph, we can see loss of the P63, that is the basal layers. Then we have entities in the intraductal proliferative lesions. We have high-grade pin, atypical intraductal proliferation, and intraductal carcinoma of the prostate. So all these three are said to be the spectrum. Say high-grade pin, then it progresses to atypical intraductal proliferation, and then subsequently to intraductal carcinoma. In context with high-grade pin, this is to be remembered that low-grade pin we don't report at all. So low-grade pin is not to be reported. Then if the cytological atypia, it is slightly higher than what we see in a low-grade pin. So we will call the entity as high-grade prostatic intraepithelial neoplasia. The prognostic significance of this thing is that once we identify it and there is no associated lesion or carcinoma, so it can be conservatively followed. One caution which has been given in the WHO 2022 is that the diagnosis of cribriform high-grade pin should not be given. So because the cribriform pattern, it can be seen in the intraductal proliferation of, say, atypical intraductal proliferation, as well as in the intraductal prostatic carcinoma. So the terminology cribriform high-grade pin should be avoided. Then the newer terminology is atypical intraductal proliferation. So this is a borderline lesion which lies between a high-grade pin and it is more than high-grade pin, but then it's not sufficient enough to call as the intraductal prostatic carcinoma. The criteria of which we will see in subsequent slide. This atypical intraductal proliferation has 50% risk of prostatic carcinoma, and it has got adverse pathological findings in radical prostatectomy specimens, and it might represent a low-grade spectrum of intraductal carcinoma of prostate. If in doubt, we can perform P10 and ERG on selected cases. And here we can see this atypical intraductal proliferation, where the basal cell markers, they are still intact. Then here the intraductal carcinoma of prostate, it's an important entity and important to recognize. So these are the criteria which are there. So earlier they were also there in the previous fascicle of WHO also. The only change over here is that the size criteria, the nuclear size, which earlier it was mentioned that it should be more than 6 times the size of the adjacent benign nucleus. So this particular thing has been dropped. The rest of the criteria that is there. There's the solid cribriform pattern with comedo patterns and the pleomorphic nuclei. So all these things are there. So what are the importance of this entity? It is associated with high grade and high volume prostatic carcinoma. Once we identify IDCP in needle biopsy, so there are chances that we are missing out high grade carcinoma. So for this and as well as for the atypical intraductal proliferation, if that is the only diagnosis on needle biopsy, we'll have to undertake a repeat biopsy to identify any invasive component. Again, this is an independent adverse prognostic factor associated with unfavorable pathological parameters and poor outcomes. And this has to be reported in both needle specimens as well as in the prostatectomy specimens. Then cribriform growth pattern, again, we'll have to identify if we are finding in needle biopsy and prostatectomy specimens. So this is the criteria where we can see, we have to identify transluminal bridging, lack of any intraglandular mucin, then lack of contact between majority of glandular cells with stroma, then clear luminal spaces which should occupy less than 50% of the glandular circumference, and then dense cellular proliferation that should be more than 50% of glandular lumen. So when this cribriform growth pattern is there, we have to identify and then try to distinguish whether it is atypical intraductal proliferation or IDCP. Then in the Gleason pattern, so we all know, we report Gleason pattern as the most common and then the highest, second highest pattern. So this is the same thing is persisting in prostate biopsies. In radical prostatectomy specimen, if the tumor volume is at least say 5% of tumor volume should be there for the higher grade. If it is less than 5, then it has to be the most common and second most common. But if it is more than 5%, then it will be the most common and then the pattern which is more than 5%. So the higher grade. So this is how it has to be reported. Then very important entity is treatment-related neuroendocrine prostatic carcinoma. So this is a carcinoma of prostate which shows neuroendocrine differentiation, and it is found in 10 to 15% of patients with castration-resistant prostate cancer. And it usually develops after the use of androgen blocking therapy like enzalutamide or abiraterone, which we give to the patients. And this treatment-related neuroendocrine prostatic carcinoma, basically it develops from the transdifferentiation of adenocarcinoma, and it will show TP53, RB1 and PTEN loss. The prognosis is poor once we identify it, because if you see here, so the prostatic carcinoma without neuroendocrine differentiation will have, say, overall survival of 53.5 months as compared to 7 months after diagnosis of this particular entity. Therefore, the identification is important. How do we identify? So in pathology, we will identify these neuroendocrine differentiation either as a small cell component or it may be large cell component. The large cell component, though it is very rarer, small cell carcinoma component, we all know, it will show the morphology of small cell carcinoma elsewhere, and it also shows the small cell features. Say, for example, the neuroendocrine markers will be positive, as well as TTF1 positivity will also be there on immunohistochemistry. So P53 staining will be positive, TTF1 will be positive, and Ki67, as we expect in any neuroendocrine carcinoma, will be more than 80%. Prostatic markers will be negative, and the neuroendocrine markers, they will be positive. Then there is one entity which is Penneth cell-like neuroendocrine differentiation. Now this entity has to be distinguished from, say, neuroendocrine treatment-related neuroendocrine carcinoma, because in prostatic adenocarcinoma, especially when it is a higher grade, we may find the differentiation of Paneth cell-like, where we can find the cells with neuroendocrine differentiation having granular eosinophilic cytoplasm and abundant cytoplasm with these neuroendocrine cells. Then we have neuroendocrine tumor, which is a pure neuroendocrine tumor that's very rare. And this well-differentiated neuroendocrine tumor, they needs to be distinguished again from the neuroendocrine prostatic carcinoma. The reason being, these neuroendocrine tumor can also show extra prostatic extension. They may show vascular invasion, and they may show seminal vesicle invasion. So the invasion per se, whether extra prostatic or in the adjacent organ, does not confer the diagnosis of neuroendocrine prostatic carcinoma. It is a well-differentiated neuroendocrine tumor only, and morphologically we have to distinguish, because the markers of neuroendocrine markers will be positive in this particular entity as well. Then coming to the last slide, this is the last slide, the molecular genetics of prostatic cancer. So in the molecular events, we have MYC overexpression, inactivation of GSTP1, and then CpG island promoter hypermethylation. So these molecular changes, they are consistently present in prostatic adenocarcinoma. Then in metastatic settings, so we should try to identify the target. So we have HRD testing, we have MSI high testing, and CDK20 deficiency. If we identify these deficiencies in a metastatic setting, we can institute the PARP inhibitors therapy for HRD. We can have the immune checkpoint inhibitors for MSI high and CDK12 deficiencies. So these are the concluding slides. These are some other points which I did not cover. So mitotic counts again has to be expressed as per millimeter square, which is a norm as everywhere now in every WHO fascicles. The tumor size has to be mentioned in millimeters, and the other points, the variants, distinction between this subtypes and patterns that we had seen. So all these things I think we had covered. So thank you very much for your patient listening.
Thank you, Dr. Patne. And I think one of our chairpersons has one.
Yeah, sure.
Thank you for nice collaborative talk. So there are two questions, one for prostate and one for bladder. So for prostate first. So nowadays transperineal prostatic biopsy is becoming a standard, and at many centers it already has become standard. So what do you think? Is there any difference in finding pathology or the yield of the prostatic pathology in comparison to the transrectal biopsy specimens? Means some pathology types which were actually not found routinely in, or found less commonly in transrectal biopsies, they are more commonly found in transperineal. Is there any difference? This is first question. And for bladder, what features would suggest the urinary bladder paraganglioma? That is again an uncommon, but so how can we go for a diagnosis of paraganglioma?
Okay, thank you, Dr. Himanshu, for these two questions. The first question pertains to the difference between the approach of, say, transperineal versus transrectals. So we have actually limited experiences. So in our center, how are we going? I think we are doing transrectal or transperineal. I actually have no idea about this particular question. What is the difference in the, say, morphologically or the yield of the tissue between transperineal and transrectal approach? So I'll be unable to answer this question. Coming to your second question, the paraganglioma. Yes, paraganglioma or in the bladder. Of course, it's the close differential diagnosis of paraganglioma is bladder carcinoma, especially high-grade bladder carcinoma. So as a pathologist, we have to exercise our caution. So whenever we find, the nest kind of tumor cells surrounded by the thin vasculature, so we should actually think of the paraganglioma as one of the differential diagnoses. The other important thing about paraganglioma is that once we have, especially in the radical cystectomy specimens, the overlying epithelium will be more or less normal, and then the tumor will be growing, basically submucosal. So that is one thing by which we can actually distinguish. And morphologically, if there are any clues, as I had said, that there will be the Zell-Wellen kind of pattern, which is characteristic of any say paraganglioma or pheochromocytoma like tumor. So there we can use take the help of immunohistochemistry, where the neuroendocrine markers will be positive in paraganglioma, whereas those will be negative in the bladder cancer. So bladder cancer ke liye that's an important differential diagnosis.
Nice talk, Dr. Shashikant Patne was. I have one question. As per my clinician experience, what we do, if there is a low-grade PIN, then we follow up by PSA only. If there is high-grade PIN or intraductal carcinoma, then we have to repeat the biopsy. So if there's difference in the follow-up of biopsy, like we have to repeat at 3 month interval, 6 month interval, or if there is high-grade PIN, we have to repeat at 3 to 6 month interval, or if there is intraductal carcinoma prostate, can we directly go for radical prostatectomy? If there are other adverse factors like high PSA, there is Gleason score is high.
Again, it's a clinical question. Would be difficult for me to answer, but what is the actually the norm that I am not aware of. So basically, if we identify any intraductal prostatic carcinoma or high grade PIN, definitely we should repeat the biopsy in order to identify if there is any missing carcinoma component which is there. So we should try to repeat the biopsy. The interval again has to be judged by the clinician.
Are you doing molecular testing for prostate and bladder cancer currently?
Currently, no, we are not doing it.
And what are the challenges